I will carry forward what where Dr. Pandeyji has left. Shh. I'll carry forward from where Dr. Pandey has left. Now, understanding myopia. Myopia is a complex multifactorial disorder involving interplay between genetic and environmental risk factors. Nevertheless, despite a plethora of myopic research, the molecular cellular mechanisms underlying myopia development are still not well understood, undermining the search for a most effective control strategy. Now, first thing, the genes. Genetic mapping studies have identified over 250 chromosomal loci. Loci means the place where the genes are placed, linked to myopia. These loci amount only to 10% of variants linked directly to myopia. That means what has been found that only the effect of genes directly in myopia is only 10%. So what happens to the others? Because majority of genetic variants are of very low expression, means they are very weak genes. It's very, very rarely that we got an autosomal dominant and then it will come into. So genetic expression is modulated. Now what expression means? How do the genes express? Means how much the myopia, you would get the myopia, is modulated by the impact of environment. This is the latest now the crux which are on refractive development and the determines the progression of myopia. So can we change the genes to control myopia? That is the first thing we have to do. Genes are what we inherit and are embedded in stone and cannot be changed, but their expressivity can be controlled. That is what is important. Now the second thing is the natural environment, what Panditji was talking. The human eyes, which have evolved over millions of years, were not programmed to do so much of near work. They were meant to see only for distance, only as people were mostly wanderers, farmers, and roamed over mountains and green pastures. So the eyes were not made to do some they were doing now. What has happened then? What has happened is the near work which has come into the picture. More recent longitudinal research and their result published in 2021 as 2021 have found a definite relationship between myopia and near work. जो पांडे जी बोल रहे थे उसको मैं और आगे बताता हूँ. Rather than daily hours of near work, it is the absolute working distance. You see, it is the absolute working distance and the duration of continuous work which has been linked to the causation and progression of myopia. Means if you work for 8 hours constantly, that is a detrimental factor to give you this thing. But if you give breaks, if you want, because now I'll tell you what happens later on. The exact causative mechanism is not known, but presumed that accommodative stress and prolonged convergence triggers release of certain transcription factors from retina, choroid, and sclera, which promote axial elongation. Means they have found that the accommodative stress releases certain transmitters, is matlab what is the genetic expresses, and that causes the elongation of the eye and retina, this thing. The third is illumination. Now low illumination reduces the depth of focus, compulsorily bringing the object nearer to the eyes to see clearly, which again increases the demand on accommodation and resultant damage. Then lack of accommodation. This is an important factor for progression of myopia. Lack of accommodation means the required accommodation needed for that particular distance is not there and is not coming into play for that particular distance. So again, if it is lack of accommodation, the patient accommodates, goes much nearer, brings the object nearer, and again the accommodative stress continues. Then another important thing is defocus at the posterior retina hyperopia. This is one of the most burning topic of today and one of the most important research areas, and we are going into that because if this really proves good, then we will be able to control myopia for a long time. Now, what are the measures of control of progression of myopia? One is optical. But that doesn't help because either you have bifocal or whether you have progressive, that doesn't control the myopia. It's only management of myopia, not the control of myopia. So then what happens is orthokeratology is the one where we can have a control of myopia. Then the control, we don't have time, that's why I'm not telling you what is orthokeratology, you must be knowing it. Then the control of hyperopic defocus. Now we have two areas in this, the defocus contact lenses and the defocus spectacle lenses. Now what is this basically? Now this is that the eye does not only work from the center of the eye, that is the fovea. The image falls on the whole of the posterior pole, which is almost about 15 degrees of the central part of the. So in the center of the fovea, the focus would be exact, but as you go away from the fovea, the rays are forming behind the retina, and that is what is known as hyperopic blur or hyperopic defocus. Now when this hyperopic defocus occurs, there is always a tendency of the eye to focus the image at the posterior pole also, and therefore there is an attempt of elongating the eye, because then you have so many, the expression of genes start and the transcriptional factors start coming to play, and they all attempt to make the eye little more longer, so that the hyperopic blur is eliminated and the image focuses also on that areas. So because of this thinking, see now on the you see this thing, this area, when you see that there is a lenses which is a central myopic, which focus the image on the central retina, and you have a plus lens in the periphery. It is both in the contact lenses also, defocus contact lenses and defocus lenses. So this plus element, they put +3 in the periphery, so that the focus which is going as a hyperopic focus becomes a myopic hyperfocus. We want to bring image away from the retina, not behind but in front of the retina. So it will reduce the impetus or the triggering effect of elongation. Outdoor activity is what he was talking. Accommodative research has proved that 1 hour of outdoor activity counteracts 6 hours of near work. Illumination. Sunlight stimulates the release of dopamine from retina, which is a modulator of eye growth, which has the main work. Even atropine, the low dose atropine, releases dopamine from the emicrine cells. So if you work in the sunlight, dopamine will be released more, and you will have this thing also. Now these are the certain agents which have been now tried, which are in the research and going to come into the picture, into the market, where all these, which are acting, some drugs act on the retina, some on the sclera, some on the this thing and all those. Now, the pharmacological agents which have been clinically proved is one, dopamine. Dopamine is produced by emicrine cells from the retina, from tyrosine is released in retina, choroid, and sclera. It is released from all the 3 layers of the retina. It regulates the eye growth and controls the excessive eye elongation. Thus, it acts as a stop signal for abnormal axial growth. That's why we want dopamine. It has been tried that dopamine has been used as a tablet also. The research is going on. It was used for myopia but doesn't affect there, but it does affect on the myopia. Then atropine, we already know. Mechanism of action, because this is important, I'll just go through it for in half a minute. Atropine helps in the release of dopamine again. See, so it also helps in the release of dopamine from retinal amical cells, which is known to block the axial growth. It blocks the acetylcholine receptors also, because after all, atropine also blocks the muscarinic blocker hota hai wo, it also blocks the acetylcholine receptors also. So it blocks the acetylcholine receptors present in the tissues of choroid and sclera, thus preventing the release of neurotransmitters involved in eye growth. Third, atropine also inhibits the production of chondrocytes and glycosaminoglycan, which is the main structure of the sclera, and thus inhibit eye growth. Pirenzepine is another type of muscarinic blocker, which also helps. This is highly effective because it is a selective blocker of M1 and M6. We have 6 muscarinic receptors in our eye. The atropine acts in all the receptors, but pirenzepine in 2% dose is an ointment, is available in the market, used twice daily. Methylxanthine, not very important. Now, having known the effect of muscarinic receptor blockage, similar, but just half a minute. वैसे भी लास्ट है मेरा, उसके बाद तो चाय है, कुछ नहीं है। ओ यू हैव कम, ओ हेलो हेलो, आप मैंने तो देखा ही नहीं आपको। नहीं, अब वो तो मैं उसमें कुछ नहीं कर सकता, वो 10 मिनट आगे कर लेना आप। ओके, हाफ अ मिनट। So once this, so similar non-selective anticoagulant also expert like trachomet have been tried, it doesn't affect. Once this new vista of pharmacological control of myopia production opened, there was a flood of researchers and drugs which could influence the eye growth at various sites. So three main sites have been already we have been targeted: muscarinic receptor blockers agents, dopaminergic pathway agonist, which act like dopamine, and drugs affecting the scleral architecture, which prevents the loosening of the structure. चलो, thank you very much. अब आगे मिड टर्म में बोलेंगे.
Thank you, Professor Shukla, for a very interesting talk. It's a very huge topic and a lot of things are there, so I think it's not possible to cover in a short